This is the Board of Directors of the Kern Valley Healthcare District. It's Monday, July 11th at 1 o'clock, and we are called to order. We have an agenda before us, but we do have a couple of changes. But before we approve the agenda, let's do our flag salute and invocation. And Gene, if you could lead us in our flag salute, and Mark, if you could do our invocation. Thank you both.
Okay. Is the flag comes first or the invocation?
Yeah, for the way it's listed on our agenda, the flag comes first.
Okay. If you could raise and face the flag and repeat with me. I pledge allegiance to the flag of the United States of America and to the republic
which stands one nation under God, indivisible, with liberty
and justice for all.
Thank you, Gene.
Yeah, if you would care to join me and bow your heads, Heavenly Father, we just ask that you go before us in this July edition of the Board of Directors meeting for Kern Valley Healthcare District. We ask that you help us make and guide our decision-making and directives, and just help us get through this pandemic that we're dealing with. It's coming back to rear its head again. And we just ask that you be with all those folks that are suffering with it. And just bless this meeting in Jesus' name. Amen.
Amen. Thank you, Mark. Okay, so our agenda, we have one change for sure. On item 6 under contract review on the agenda, there are several contracts listed, and those are all incorrect. I think they were a carryover from the last agenda. And all the contracts that need to be approved on consent are on page 34 in the packet. Those are the correct contracts, but the agenda does not have the correct ones posted. For all the contracts that we're going to be approving on consent, they're on page 34 of the packet.
Those were all approved by Finance Committee, correct?
They were all approved by the Finance Committee.
Okay. Do we need a motion to make that change or anything?
And there's one other change before we do that, Gene. Thank you. We're going to have the addition of a closed session item. Scott, can you speak to that?
Yeah. Late Friday afternoon, we received an email from the district's trial counsel in the Quinn case. And on August 8th, they are having a mediation, and they asked for the district's settlement approval, which we will discuss more in closed session. But we do need to add this as a closed session item. And this did come in, as I said, late Friday afternoon, so it arose subsequent to the posting of the agenda. And both Beta and our trial counsel have asked for this so that they can prepare for that mediation. So with the board's consent, we'd like to add that as a closed session item. It will be the second one on the agenda. And it will be existing litigation, Quinn versus Kern Valley Healthcare District.
Thank you, Scott.
Okay. Do we need a motion for those changes?
Please, Gene. Thank you.
Okay, I'll make a motion. We accept them as presented.
Do we have a second?
Yes, sir. I'll second, Ross.
Thank you, Fred. John, your vote?
Yeah, and just to clarify, this is just the approval of the agenda, not the consent agenda, right?
That's correct.
Okay, yes, I vote yes. Okay.
Fred,
Yes.
Gene,
Yes.
and Catherine, you're there.
Yes.
What we are approving, I don't know if you caught the caught it all. We're just modifying the agenda.
Yes.
Okay. And I'm a yes. Thank you for that. We now have an approved agenda. We'll go to item C, public comment. This portion of the meeting is reserved for comments from members of the public who want to address this board on items that are under our jurisdiction, but not on today's agenda. Do we have any members of the public wishing to be heard? Okay, seeing none, then we'll move to the consent agenda. And all the items, this is item D, all the items on the consent agenda will be approved in one motion unless a member of the board or a member of the public would like an item pulled from the consent agenda where it can be discussed individually.
Okay, I would like to pull G 3 and 4.
Let's see, where is that? G isn't on our,
Okay, it's the budget from and the marketing coordinator. Job
what item number are we looking at, Gene?
3 and 4.
No.
Are you looking at
June 6th.
July 11th agenda?
Yes, no, I'm looking at the June 6th approval of the marketing coordinator job description and the budget
Last one.
that's for June 6th.
You got me lost here, bud.
Page 8.
Oh, that's the minutes from the prior month's meeting.
Yeah, right. That's on the consent agenda, right?
Okay,
Yes.
so you want the minutes pulled.
Yes,
You want to discuss,
discuss 3 and 4.
okay. So items 3 and 4 pulled from consent. Okay,
Ross, I think it's item number 1 under the consent agenda that we could pull.
there it is. Thank you, Heidi. So item 1 from consent. Gene, did you want the finance committee meeting minutes pulled for
No.
discussion?
No, just want to discuss those two things, the way they were, or the way they were presented, but,
Okay, but they're on the board minutes of June 6th?
right.
Okay, so we'll just pull that one item. That'd be the,
The budget and the job coordinator.
no, we're just pulling the minutes off so we can discuss them.
Okay,
Okay, so item 1, Board of Directors minutes of June 6th are off consent. Everything else remains on consent.
you need a motion to,
Yes, I do.
okay, I'll make a motion, we approve it with the.
Thank you. Do we have a second?
I'll second, Ross.
Thank you, Fred. Gene, your vote.
Yes,
Fred,
Yes.
Catherine,
yes,
John,
Yes.
and I'm a yes. Okay, so we will go directly to the June 6th, the Board of Directors minutes. And what would you like to discuss, Gene?
okay, the first one on the marketing coordinating job, we had a long discussion, and it says in there we had a long discussion. And as part of the discussion, they've agreed to remove that from the budget. It had no place in the budget, it had no place, period. And so I've heard this week, Tim say twice that since it's in the budget, he can go ahead and hire somebody whenever he feels like it. And that's the board, the board did not agree to that.
That wasn't quite what I said, but
When I,
And that wasn't, let me start with my clarification. When I do budgets over the years, and I've done 35 years of budgets, my understanding is the board approves a set dollar amount for expenditures. Any individual line item that might get discussed after the fact can also be disapproved, which in fact, that's how it happened, because the board approved the budget which has a specific dollar amount, and then we disapproved one line item in the budget. I have to go off the assumption that the board, the numbers that were in the financial statements that the board approved is the official numbers that are in the budget. Now, whether we execute one particular line item, like a marketing position, we have to honor that request, but that doesn't, in my opinion, it changed the total amount the board approved as it relates to the budgeted financial statements.
right, I agree 100%, but my problem was at at both meetings, the personnel on that, Tim said, well, we can go ahead and fill that position. And I was there listening. I know it's not recorded, but we can go ahead and fill that position since it's on the budget.
I'm not sure he said it that way.
Well, maybe
My
I
point was, again,
confused about it, but can you unconfuse me? Is it is that position off the budget?
Yeah, well, that position was not approved by the board for addition. Okay, so the issue is if we wanted to do something else, then I would have to come up with a new job description and then bring it back to the board to get approval to do that. Now, the issue is if that happens and the board ultimately does approve that, then the monies are then already in the budget because it's a part of the total budget.
But
That
you
was,
can't-
that was the point.
But you can't act on anything that's in the budget because it's not in there.
Correct.
You have to talk to the board first.
Yes.
Okay, then everything is awesome. That's, Kath, does everybody agree with, there's nothing in the budget for that? Oh, well, I'm sorry. There's no description in the budget for that. We could add it on if Tim brings it up and we want to add it on.
Mhm.
Fred and Catherine, and does everybody agree now? I was confused by a few comments. Maybe I didn't understand how Tim was saying it.
Yeah, that still doesn't make sense. I thought if my understanding was, and that's just my understanding, that if we pulled the position, we were pulling the monies for that position also.
I can certainly do that. And that's an important clarification that I can take those dollars out of the budget.
So that
Well-
probably requires a separate action, and the action to revise the budget is not on today's discussion. So we probably can't do that on today's agenda, but realistically, I would like to see this position come back modified so that it's acceptable to a majority of the board members. And if it, perhaps a part-time position would be more appropriate, but I don't want it to see just go away completely. So
Well,
I guess I'm asking that it stay in the budget for now. We're not going to hire it until
It's not in
some
the budget.
iteration of it comes back to the board for reconsideration.
Well, I would personally would like to see it removed. That was my understanding when I voted for it and made my comments, because $100,000 is money that could be used for something else, whether it's contingent on the building or something else that comes up. If we need security again or something, but I think that's just my personal opinion. I would like to see it pooled.
Having it in the budget doesn't mean the money is going to be spent.
No,
Let me just say, I'm sorry, everyone. All we're talking about right now is approving the minutes. If you want to change the minutes, we can change the minutes, but now is not the appropriate time for a discussion of what is or is not in the budget.
Understood.
Okay, Scott? I went over, and the discussions that we had, long discussions, have been edited. They're not in there. What our discussion was, how did that happen, Scott?
You guys do not have narrative minutes that contain all of the discussion for two reasons. One, your minutes would become unwieldy. They'd be so long. And two, you keep in perpetuity a recording of your meeting. So if anyone wants to go back and listen to it, they are able to do so.
The recording has been edited. It's not in there.
I'm not aware of the recording being edited, so I'm not sure what you're referring to.
Actually, we
Okay,
have-
can you tell us again what's required? We have rules on what can be edited. Ross, are you aware that those minutes being edited?
I don't believe any video has been edited. I haven't heard of that.
What you've done in the past, and we've had discussions.
Well, we had a policy addressing that, but
Board meeting.
I don't believe that policy was ever approved because the minutes cannot be edited. That we ended up on advice of council saying we can't edit the minutes. The public record is the public record, period. what we said in public is what was said.
Okay, then do we change the minutes to reflect what I understood to be said? And that was that there would not be a job description in the budget. The money could stay. I don't really have a problem with the money staying. It's because we always can use different things comes up.
You know, the minutes say the motion failed. What more does it need to say?
Oh, no, what the minutes say, the job description, we weren't talking about the job description. We're talking about the job itself. It shouldn't be in the budget.
Well,
The-
what was at the meeting that day, Gene, was in fact approval for the job description. And that was what everybody was voting on. And that was voted down.
So,
So the job description doesn't exist, so therefore I can't hire somebody into a position that doesn't exist.
okay, so the position doesn't exist.
Correct.
Uh,
Well, like I
Okay,
said, by the time like that was done, the budget had already been finalized, I believed. And so those dollars stayed in there. So, I mean, that, like I said, Dave can certainly pull them out if that's the wishes, but again,
Yeah,
Scott,
Catherine-
that's a different discussion.
Captain, I don't have a problem with it,
Well-
the way you just talked.
Well, if
but-
no one else has a problem with it, that's fine. It was just my understanding. It wasn't just the position or the job description. It was the position itself.
It's, yeah, and it seems like they want to hire somebody that's gonna be able to make us look good to the community, so they'll approve the next prop. And it's illegal for us to use hospital money to do that. That's one fact.
Nobody has said anything about a prop, so I,
Okay, well, it's gonna be there, and they want that person to make us look good, which is, it's fine if the community got all the facts and they want to do it. But
This was just normal ongoing business of
I
trying to.
know, Tom.
So that's all.
Okay,
Alright.
Gene, I'm going to cut off this discussion because it's really not relevant to the minutes, which is all we can talk about.
Okay, so there is nothing in the budget from the minutes have changed to reflect that.
There was no official action to change the budget because it wasn't on the agenda for consideration.
So there's no job in the budget since it wasn't approved.
There was no job description approved. It does not exist as part of our ability to hire anybody.
Okay, all right, thanks, Ross.
All right. Then we will move to,
Wait, hang on, you still need to approve those minutes.
oh, you're right. Thank you. Would anybody like to make the motion to approve the Board of Directors minutes of June 6th?
so moved.
Thank you, John.
Second.
Thank you, Fred. John, your vote?
Yes.
Jean,
Yes,
Fred,
Yes.
Catherine,
Yes.
and I'm a yes. Okay, so we will move to item E, foundation reports. Do we have a member from the foundation?
Good afternoon.
Hi, Debbie.
Hopefully everyone's doing well. There's lots of stuff coming up. July 21st, the foundation will be installing some new officers, and so we will have a new president. Colleen Bulgarelli has agreed to serve as president, so we're pretty excited about that. August 2nd is our next blood drive from 8 o'clock till 1 o'clock in the hospital parking lot. And then River Rhythms is just around the corner. Our first concert is on August 5th. Carita Rose will be playing, and they're kind of a swampy rock country band. That's my report for the foundation.
Any questions for Debbie?
No, sir.
Thanks, Debbie. Okay, the auxiliary report,
So I'm going to also give that one.
right?
I just want to let you guys know that over the past couple of years, the auxiliary has provided over $200,000 that went towards services and medical equipment for the hospital. And that was even with the closing of COVID, several times they were closed. And then we're doing a Christmas in July on July 30th. So they've got a lot of decorations and things they'll be selling, and that goes from 10 till 2. So if you have nothing to do that day and you need Christmas decorations, you might want to come out. And the auxiliary cleared a little over $5,000 during the month of June, and that was taking into account that they were actually closed a couple of days due to COVID, and that is after expenses. And that's my report.
That's terrific. That's just wonderful. Thanks, Debbie. Any questions, comments for Debbie?
No, thank you, Debbie.
Where is she on the screen?
Hesdy.
SD.
Oh, okay. I thought that was has been.
Maybe.
Okay, medical staff report. Dr. Finstead.
All right, thank you, Ross. I have three meetings to report on. The first one was the Pharmacy and Therapeutics Committee meeting on June 8th. We again discussed the COVID-19 issues under old business. We also discussed the corrections for the recent survey. We reviewed and approved three policies, one regarding high alert medications and independent checks required by nursing staff when these medications are given. Also reviewed and approved was the temperature monitoring policy, and then also the sterile compounding immediate use preparations. We have another policy pending before the committee that is waiting input from the Antibiotic Stewardship Committee meeting, which will be meeting this month. That's a policy regarding penicillin allergy testing. Then we reviewed our regular reports, including the medication error reduction program, medication area inspections, medication shortages, temperature alert incidents, and the environment of care rounds. Then the Medical Executive Committee met on June 28th. We reviewed and approved one credential file for a new provisional radiologist to teleradiology. We also reviewed the above mentioned policies from P&T. We were also given a preliminary report on a mock survey regarding the medical staff office. And I believe now we have the written report, but at that time of the meeting, it was still still pending. We reviewed updates to COVID-19 issues, and then we also reviewed our regular reports, including medication shortages, procedural sedation policy, and physician QI monthly report. Then the utilization review committee met last week on July 7th and discussed the denials of payments along with authorization for admission. Apparently denials of payment are a issue again, or maybe a bigger issue than is usual. Also reviewed the average length of stay. Currently, I think we have a waiver for our average length of stay, which is for 4 days. A lot of the people that get admitted, so for instance, people for alcohol withdrawal and also for the remdesivir treatment, those are all 5-day length of stay, 5-day treatments. And we have certainly been impacted by getting people in that we can't transfer. So as part of that, the hospitalists and the ED physicians are using a handoff tool. This is particularly related to the types of patients, the types of medical problems that we have difficulty dealing with that are inappropriate for our facility. For instance, end-stage renal disease, behavioral issues, which I think pretty much everybody knows. We've just get totally stuck with that, and nobody wants to accept these people and transfer. We end up keeping them, housing them here for it could be weeks. And then also reviewed were the regular monthly reports, medical records, and utilization review. And that is the end of my report, unless anybody has any particular questions.
If if someone comes to the emergency room with behavioral problems, then we transfer them immediately or have the ambulance taken to Bakersfield, that we can't deal with it.
Well,
That's against the law.
Oh, okay. Then I'm confused on what he just said.
I'll talk about it.
Okay, all right, thank you.
Okay, Mark.
Thank you, Dr. Kingston.
Yeah. Basically, anybody that presents is required to have what's called a medical screening exam and things, and that's legally defined in the legislation and things. But I'll let Mark kind of talk to that.
Okay, thank you.
Any other questions?
Dr. Vincent, I do. You mentioned a couple of things. One on the mock survey. I don't know, you don't have to go into the details on what the survey was asking for. My question, I guess, is are we on top of that? Are we making the changes necessary that came out of there so that when the real survey happens, we'll be ahead of the game?
Yes. We are in the process of working on that. Marie Quick from medical staff offices working on implementing those changes and things.
Okay.
And that information will be coming, the ongoing information will be coming to executive committee, for our review and analysis and things.
Terrific. All right. And then the second item I wanted to ask you about was the denials of payment. Are those insurance, are those payers playing games with us, or are we not recording things the way they want them recorded so that we get paid appropriately?
So I am sure there are several people at this meeting that could answer that question a lot better than I can.
Okay.
Getting a report and things. So I would turn that over to Tim and David, who have way more information than I do about that.
Thank you. All right.
Welcome.
Okay. Any other questions or comments for Dr. Finstead? All right. Thank you. Appreciate your report.
Sure, my pleasure.
All right, that brings us to the Chief Executive Officer report. Tim.
Thank you. Nice to be back. Today's my first day back after about 3 weeks of COVID. Got hit and came boomerang back and hit me a second time. Anyway, glad it's over with and feeling great. And like I said, anxious to get started again here. Just a couple of things I want to talk about was CDPH survey. Again, we did have that. Very pleased that we finally have gotten past that. It's been accepted as being in substantial compliance. Again, thanks to all of our staff, Mark, Heidi, our pharmacy staff, infection control, you name it. Had a whole team of people working on this, and everybody just did a great job of responding to that. Some follow-ups on that. Pharmacy HVAC system has been installed. Obviously, that's up and running. We did, in fact, have a new environmental hood test done, and which came back clean. We wanted to make sure that thing was completely, the construction aspects of that were completely done before we cleaned it again, before we actually asked the company to come back out. So that was our third straight clean survey in there. And so we're appealing to CDPH to go ahead and remove the non-emergent compounding issue down in Bakersfield. At this point in time, what we're waiting for is that the fire marshal has come out about a week or so ago and approved the unit, and it met with his satisfaction. So he's signed off on it. He apparently sent the report back to the state, and hopefully once they have that, then we will get the approval sent down to be done with that process once and for all. So that was great news. We have a meeting set up on Friday, July 22nd with the VA staff, trying to move forward with seeing how that we can enhance our services that we provide to our veterans here in the community. That'll be at 1 p.m. on 7/22. And anxious to get started with that and see what more we can do. As we indicated that apparently we do have quite a few veterans that are already utilizing our services through the clinic. My conversations with Greg. And again, I don't know that the VA, how well the VA knows that that's already in process. So this is going to be a good opportunity for us to both get up to speed on what each of us are doing and how we can hopefully work together to kind of make this even better. And then we, again, also had on the 4th of July, had a great celebration. This was, I believe, the Friday before the 4th of July. And picnic out on the front lawn for the staff. They had hot dogs and popcorn and you name it, chips and dips and all kinds of stuff out there. They did have some games. They had a cornhole game out there. They also had a pie toss contest, which Mark more than graciously participated in. I have pictures if anybody's interested.
That's only because I don't have to wash my hair after the pie is in.
Yeah, exactly. It was a mess. It was a mess. But Mark and Tiffany, Tiffany Friesen from our.
And there was no tossing involved.
They were supposed to stand behind one of the benches out there and toss them across at them, and because nobody was hitting them, they actually allowed them to then go beyond that point. And Mark kind of got his share of them smeared in his face. It, like I said, got pretty messy out there. But everybody was a great sport about it, and everybody had a lot of laughs. And so it was, I think it was really good. And I think the people really enjoyed just the camaraderie and just the ability to get out and just kind of share some time together. So it was very nice. And we'll kind of do a lot more of those things as the summer goes on. Just wanted to give you a quick update on the Nectar system. Again, we've had at this point 184 shout outs already from our staff for other staff members, which was great. And, we will continue promoting that. And so, again, staff are being really generous with their points and so forth, which is really wonderful to see. Again, it's doing what we hoped it would. And so we'll just keep an eye on that. There's some reports that come out that Gary's made me aware of and how to get those off now, so we can keep you apprised. And every couple of months, I'll come back and give you an update on that. Last thing I wanted to talk about is, and that's a pretty big one, is salary issues. It's come to our attention that some of our surrounding hospitals are beginning to make significant changes in their wages. Ridgecrest, for example, just did a big increase on the number of their employees out there. We're still trying to determine exactly who all was included in that, but we know they raised their CNA rates up to $20 an hour, which is considerably higher. What was that? You're on mute.
Sorry, wasn't it 25 or was it?
No, 20. It was 20.
Okay.
The city, I get the other one's 25.
All right, sorry.
Yeah, they raised it 20, and then they gave their LVNs another raise on top of that. Their PAs and their mid-levels were all given significant bumps up to about $65 an hour, we were told. And then, we heard rumor also that we haven't not yet corroborated that apparently Adventist Health Bakersfield and their hospitals are doing something similar. And then, like I said, we just happened to see today, apparently, that the unions at Kern Medical have just authorized a 3-day strike beginning July 26th at Kern Medical in Bakersfield. The hospital had offered their workers wage increases of between 18 to 28% over a 3-year contract, significant increase. And those rates were turned down. They were not, they were viewed as not reasonable or financially feasible. So that was one issue. The UC system, the nursings for their hospitals just entered into a new agreement that was announced. They had a 16% increase over the life of their 3-year agreement. So again, others, there's like 6% per year that they're going to be raising their rates. And then this was a real interesting one, but it just kind of goes to show you what's going on out there, with the shortages of staff and everything else. LA City Council voted unanimously in favor of a $25 minimum hourly wage for workers at privately owned healthcare facilities. And this is to approve a new minimum wage for these special classes of people. And this affects hospitals and integrated health systems and dialysis centers. But the roles that covers are for clinicians, nurses aides, technicians, maintenance workers, janitorial and housekeeping staff, groundskeepers, guards, food service workers, and other clerical folks. No managers or supervisors were included in that. So this is kind of what's happening. And, again, with just the increase alone that we've heard of since from Ridgecrest, again, some of our staff live in Ridgecrest. Our CNAs, one long-term person, who is not making anywhere near that amount of money, is now questioning, says, geez, maybe I should just go work there instead of coming here, And so it is something we're going to have to deal with at some point here. I think some of this is in response to the inflationary issues that are going on. Part of it is just, I think, the shortages, and people are they're getting into this race thing again to try and raise their waist to see they can get to who they can attract. This happened 15 years ago in LA County with the RNs and stuff like that when there was a major nurse shortage. So, and it got pretty ugly and it got very expensive. And so, like I said, while we talked about having the extra money in the budget, I'm sure that money will be used for something down the road here. But we probably are going to need, I know Gene's brought this up before about trying to do something for the employees. I really have a feeling that we're going to have to come up with something in order to get through this. This, like I said, these are increases to wages. These aren't one-time things that they're putting through. They're actually raising the rates. So this is now setting a new bar for us and our ability to hire some of the folks from these areas. So just wanted to throw that out for the board's consideration. I don't have a plan yet in place. Dave and Mark and I need to sit down and put our heads together and see what kind of a response we should propose. But I'll open it up to Mark if you want to add your comments or.
Not really. I'm seeing the rates that we're paying registries when I have to go out and get another staff member from a registry. These rates are exorbitant. We just looked at a contract recently where an ER nurse's rate is around $120 to $135 an hour. These numbers are just unsustainable. I mean, we can do it for a short period of time, but I don't know. And I don't know if the industry is going to be able to support these kind of numbers. So, and I see Dave shaking his head, and, we still have a service to provide. So somebody's going to have to shake the tree a little bit, I think.
Dave, you want to add your thoughts?
Yeah, I've seen organizations go both directions. Sometimes it works, sometimes it doesn't work in terms of trying to keep up with the inflationary demands and what other hospitals are doing. The one example I can think of, Hemet Hospital, I was in San Gorgonio, which is a neighborhood hospital. They prided themselves in keeping up and giving raises. And it was 2007, 2008. They had a reputation for paying better. Well, lo and behold, about 5 years later, they went bankrupt. And then I'm not sure the employees were real thrilled with that whole disruption of their services until they got bought out by somebody else. But my point is that there are unintended consequences sometimes that you try to do the right thing, but it sometimes in the long term, at the minimum, it probably requires for a long-term picture, any organization that dramatically increases how much you pay your people puts a large strain on requiring that the organization improves their productivity significantly. In other words, there's less people. And I'm not sure the employees, when they come to work every morning, are real thrilled to come in and there's less staff that they work side by side with, and they have to do more work and there's not enough there for the patient at the bedside. So you just really have to be careful before you get emotionally pulling triggers and understand that sometimes there's unintended consequences.
Yeah, no, it's very true. And that's, like I said, what we heard this morning was apparently that Ridgecrest did this across all positions. We haven't verified that yet. Sarah's got a phone call into their HR manager to see if she can confirm that or not. But yeah, we do know that there has been a number of the positions, obviously, especially on the nursing side, that were in fact impacted. And like I said, it's just, Mark raised this question to me before the meeting. He says like, well, what does this do to our insurance reimbursement? Guess what? It doesn't do anything. They're not going to pay you more just because you decide to pay your people more. So you either, as Dave said, you learn to live with less, or whatever. But
it does seem to be happening globally on a the cost of living has increased for everyone.
Well,
So,
and I think, what happened with COVID, obviously we had this huge demand that was created artificially for staff, and all the hospitals, everybody was scrambling to get registry staff in. And as Mark indicated, they were paying huge sums of money to these registry companies. I know Kern Medical, for example, was paying up to $9 million a month just in registry costs.
Whoa.
Humongous. And so, and so what happened is, as a matter of fact, that's one of the things that actually led to the strike that they're calling, was because they said, well, the managers, instead of giving that money to us, went out and paid all these travelers this huge sums of money instead. So they basically felt they got shorted out of that. And so, but the point was they needed the bodies. That's what they were going out and hiring the registries for, because of the influx of patients. And so anyway, so, now they're in the situation where, like I said, here they go out and offer even an 18 to a 28% increase, and that's now not acceptable. And so, so I don't know where that's going to end up, but like I said, we've got to be very careful in a response. I think our staff is going to look for something for us. As a matter of fact, I heard there were some questions from some employees that say, was the board talking about that today, and stuff like this. So, it's on their minds. And so we've got to, like I said, put our heads together and come up with something that's sound in terms of our approach and what we're going to do. So I'm not advocating at this point to do anything yet until we get a better figure of what's going on.
And I'm not necessarily negative about not doing anything.
Yeah.
I just hope, what we don't do completely handcuffs us for the future. Generally, lump sum payments that don't have long-term effect are sometimes better to try to at least help the employee in the short term, but not necessarily handcuff the organization into paying higher than what we can afford in salaries long term. The other approach could be bumping up the timeframes of when we give the pay increase. I put extra money in the budget for that purpose. If we wanted to do the increase before the normal December timeframe and do it earlier, that's another possibility, those kind of things.
Yeah. So anyway, that's it, my report.
Thank you, Tim. We definitely need to go into this clear-eyed and with a look to what the future impacts are going to be.
Yeah.
And maybe in terms of long-term investment, we figure out how to purchase Ridgecrest Hospital when they go broke.
Yeah.
Any other comments, questions for Tim?
Very good report, Tim. Thank you very much.
You're welcome.
So this will be a new item for the next board meeting, Tim, that we can talk about, or at least have a discussion.
Yeah, I think we're going to have to keep this kind of as an ongoing discussion point, or at least as a part of my report. Again, just in terms of what's going on around us. Like I said, I've not heard of anything yet coming out of the Dignity hospitals with regards to any significant increases. I did have a meeting with Ken Keller up here a couple weeks ago. He didn't share any of those kind of issues or pressures on him at this point in time. But other than just a commitment to continue to work together for some rural medicine stuff. But yeah, no, it's something I think it is going on all around. I'm hearing it from other states as well. And just like I said, I think, as Dave said, and Ross, we need to keep our eyes open and, make sure that we are addressing issues carefully as we go forward from here. Anytime you do this stuff, like I said, these become permanent increases. It's kind of hard to take them back.
Yeah. Thank you, Tim.
You're welcome.
Okay, Chief Nursing Officer report. Mark.
Well, I just want to talk about a couple things. COVID numbers in the month of June were 1.6%. The first 11 days of July, the numbers are 6.4% in the ER. And our staff members, we've also had 11 staff members out since the beginning of July. That's a pretty significant number for us, about 5% of our staff. So, or 0.5. Anyway, the other thing is we've also had some effect in the skilled nursing center where they're in a yellow zone again. I don't want to talk about numbers over there for HIPAA reasons, but yeah. And so COVID is back among us. It's a very virulent strain, meaning it's very easy to get it, but it's not taking people out and putting them in the hospital settings anymore. It seems to be they come in, they get diagnosed with it, they get a couple of treatments, and then obviously the monoclonal antibodies that somebody received that I know it did well for. Just trying to be careful, Fred. I see.
I admitted that before, so.
It did work, it did help, and so I would encourage that. I don't think that the original vaccination is helping with this, with these particular strains that are out right now. So that just remains to be seen. There is approximately $120,000 in grant money available to help with medication-assisted treatment programs for patients who want to get off of the opioids. So we're looking into that. We do have to have a substantial effort on the part of the providers in the ER that participate in this, because it is an ER origin program. So it'll be originated in the ER. It's just the follow-up with these kind of programs that needs to happen. So this is the kind of grant that they offer like quarterly. So if I miss it this quarter, miss the deadline this quarter, I can look at it in the next quarter and still have an opportunity. So we have time on our side. So I really want to develop a program that's pretty solid before we get started and go apply for the monies. So the monies are there to help offset some of that cost. Our transportation service is currently providing 7 or 8 rides every day. And the new Kern Health System CEO has come out in favor of providing transportation services throughout the county to help get their recipients the follow-up care they need. I'm currently looking at drafting a letter to Kern Health Systems to extend their coverage past the end of the grant that runs out in August. So Gene, your question of a couple of months ago, how we're going to continue to provide this, I'm hoping that Kern Health Systems will just extend that number for us. And we may actually want to ask them for another vehicle to start going up and down the canyon to some of those appointments that they have down in Bakersfield for some of the services we don't have up here. We mentioned mental health services in Kern County. We have been in touch with the director for Kern, for Mary Kay Shell. Her name is Tanya Mann. And we've been in touch with Stacy Kuwahara, who took Bill Walker's place. Ross, I'm sure you're familiar with who that is. And this was during a time when we had a patient, Gene, your comment about transferring patients. We had a patient in our ER that they refused to accept for 33 days. We could not get the patient out of the ER. They had one reason or another that they were refusing to accept this. They didn't have a bed available. They didn't have a medical need. They didn't have, I mean, they were just arguing about who was going to do what. And they finally got into Kern Medical Center after we had to shake the trees pretty much all the way up to the state level. Tim was on the phone with Kern Health Systems because they're also responsible with their case management. But when you get somebody who's got a behavioral health issue and you're keeping them in an ER environment where there's stimulus nonstop, constant stimulus, That's not a healthy environment for somebody like that. Not to mention the gentleman lost, I think, 43 pounds when he was here. We tried feeding him. I mean, he was just, we were not doing him any favors. We couldn't discharge him, but we couldn't get him transferred. We called everyone from Sacramento to San Diego trying to get this guy transferred. We were told one thing after another. We made 236 phone calls. I counted them, and I counted 39 to Kern Medical Center, 36 to Mary Kay Shell. Good Sam had 35 phone calls. I mean, it was a really, really, really bad situation. So we are going to invite Stacy Kuwahara and Tanya Mann, those two individuals we talked about, up here to meet with us to show them what conditions that we have up here, and if we can streamline any transportation or transfer ability especially for behavioral health services. And so that's the end of my report.
I think that's a brilliant plan.
Heidi, did you get all that?
To see that.
Thank you very much, guys.
Yeah, I think that's a really good idea, is to invite them up here to take a look and look how you're treating this patient because you're not accepting them. I hope that
it seems like out of sight, out of mind is kind of the norm these days, and they have to understand where this patient is and the conditions. So
yeah, exactly. I hope that works, Mark. Keep us posted.
Sure.
And Dave.
Now, the question Dr. Finstead, or the issue Dr. Finstead brought up earlier on the denials, clearly this is a good example of the types of denials that we really don't have a lot of control over to make improvements. And it's a mixture. There are some areas, as we're looking, in fact, making it a bigger priority to try to find ways to improve our systems to keep denials to a minimum, but this particular example is not one of them. That has a lot of flexibility when we get treated the way we were treated on this case.
Any other questions or comments for Mark?
No, thank you.
Another good report.
All right, Dave, Chief, I forgot your title, Financial Officer. Take it away.
Dave, you're on mute.
So I'm on page 22 of the packet.
Page is up.
Can you see it?
Yeah.
Yes.
Okay, good. So to start out, we're showing a good projected bottom line for the year, even a little better than the last 3 years, 3.9 million. By the way, that still holds because we've already got a sneak peek. Here we are on the 11th of July. So we kind of have a good feeling about June. It's probably going to be at least that much or better than the 3.9. So we're feeling good about this year being a good year. We had a rebound in the month of May on the concluding summary, positive takeaways, rebound from the month earlier where we had a slight loss, changed over to a $758,000 gain. The year-to-date variance to budget was about 2.9 million ahead of budget for the total surplus. And we had some improvements in skilled nursing, went from 43 in March, 45 in April to 47 in May. Now the COVID now hitting the unit is going to slow that growth down again. Unfortunately, we won't be able to admit as much, but we were on a good pace to get those numbers back up into the 50s, and hopefully that this new event of the positive COVID cases in the skilled nursing won't be a long-term effect on us continuing back toward our goal of getting a much higher average going into next fiscal year. We felt good about how we've overall been managing our operating costs. When we compare our year-to-date 11-month numbers through May compared to the same period last year, we're only 2.2% higher in our overall operating costs. So we can feel good about our performance in managing the expenses for this current fiscal year. Probably the big negative from my perspective that's taking a lot of my time is analyzing and working with the business office and trying to find ways to get a handle on our performance in getting the receivables back down again. The days in AR went up slightly over 100 in May. But what you will see in the next month's report is we've got that number back down in the upper 80s again. So there was a good improvement in June. That I'm not really reporting June, but because I know about it, I can tell you that we're already making some good improvements. The other things I found out when we looked at the denials, part of it was a function of what I learned later, that probably the last 6 to 8 months that Chet was here, we hadn't done the normal cleanup every month or two. There's usually a few denials that have to be cleaned off the receivables totals. So it's been like over 2 years before those accounts were just sitting out there. Nobody had done anything, even though we knew, let's say 2 years ago, that we weren't going to be able to collect. So it was mostly a lot of cleanup function of what normally should have occurred earlier in the process, because you now have a new CFO and we're now getting back to doing things the way Chet had been doing them for years, in terms of on a regular basis, making sure that if an account doesn't look payable, we get it off the books instead of showing a higher and higher balance every month like we had been up till recently. So that's another new thing that we learned. The overall cash went down a little bit in May, but again, because I know the June numbers, they're right back up again at the end of June. In fact, they're higher than what we thought they'd be because of over $1 million COVID payment check that came in at the beginning of the beginning of June, which will impact how we show our year-end cash position, which will be in good shape, better than what our projections were. I'm going to go to the P&L for the current month, and I think I'll try to make it a little bit bigger. The revenues for May improved. This is about 600,000 better than last month, 9.6 million. So we did have a much busier May than we had in April. And we were able to hit budget almost exactly on line 13. You can see the total operating revenue, money coming into the organization. We were a whopping $341 off budget. So that should be a compliment to Chet and his budget, how he hit that right to he nailed he knew what was going to happen in the month of May, and we nailed it, $341. Similarly, we're very close on the expense side, where we were 0.4% off 10,000 on the expenses. So everything came in pretty much as expected in the month of May, except for one other real positive thing, and that had to do with line item 30. Even before we got the 1.1 million in June, we got a 427,000 amount, and this is the same program called it's an HHS ARP. It's called the American Rescue Plan for Rural Payments. So what the federal government decided to do is give special priority and emphasis in COVID payments to the rural facilities like us. So we benefited from having the right demographics and the right fit, that we got a much higher percentage than a lot of other hospitals that were larger than us, because they really wanted to help the rural critical access group. And besides the 427, which is 627. You see here, 200 of it was from prior year, another 400 was came in May. And then in June, another 1.1 million came in that same program. So that was like an $8 billion program nationally, and we got over 1 million of it. So we got a pretty large chunk of that money. The next thing.
Hey, Dave,
Yes.
I'm sorry to interrupt, but I'd seen a proposed rule at the federal level through CMS to begin a new designation for rural hospitals, because the federal government wants to basically ensure they're financially sound and improve reimbursements for that. Do you know much about that program yet?
You talk about the emergency
I'm
only?
glad you sent that to me. I am looking into it. What I'm hoping I don't see is that they don't require a full-blown OB program for newborn deliveries, which sometimes is the definition of the ideal rural hospital that meets all the needs of the community. Obviously, we don't do that service. It might be difficult for us to comply to get that higher designation that we have to have a full-blown OB department. As I've seen that in the past as one possible constraint to us qualifying, but I haven't ruled that out yet. And I've got a voicemail, and I should be hearing back to get more details.
Thank you.
The next thing to look at is the year-to-date picture. And again, we talked about the fact that we think we're going to be close to a 4 million bottom line. And you can see through May, we were at 3,593,000 compared to the budget of 667. So almost 3 million ahead of budget for the fiscal 22. So we pointed out in other months how this top line 11 continues to perform better than budget. Net patient revenue line 11, 30,697,000, which is 1.4 million ahead of budget and considerably ahead of last year. And again, I pointed out in prior meetings how there is a fairly big piece of that, which was prior year conservatism from Chet that we put to the bottom line from prior year understated revenues for IGTs that hadn't been recorded. So not all of this was from new revenues that came in for this year, but we still did okay this year, even without that. But this even helped even more by being able to put some of those dollars that we were fearful of not having to pay back, but now we have a better level of confidence that we won't have to pay back those monies.
I'm sorry to interrupt again, but at what point do we take the money that we are ahead and squirrel it away for our construction project?
Well, the board can take more formal action than what we've taken so far. I have taken a more liberal approach by keeping all the money in the various accounts and considering them all available for the construction project. But at the same time, they're also all available to give pay increases, to do anything else we want to do in the organization. There is not the specific way a board can handle that is through board designated accounts that you can set up that can only be used for certain purposes. And I don't recommend that because you don't really know what future challenges you're going to face. And if you have constraints put on operations, that if you really need the money in short term and and it's tied up because it's already been pre-designated, it's just a trade-off. So the board will have to decide how important that would be. But we clearly, the numbers that I show on the cash flow, and we'll just go right to that report, is truly all the money that you have available for the construction. And that's this new report that I have that has a lot of color coding, but at the very bottom, I'll make it bigger so we can see it. We see 24,409,000 And that's from about 5 different accounts. We have the LAIF account, we have other accounts that the seismic funds from the new borrowing in there, the construction reserve. The only thing we're not counting in that 2.4 million is the auxiliary money, about $400,000 that doesn't get counted in there. And also the reserve that's out there to make bond payments is not counted as money being available. Just as a side note, one of the benefits of this cash flow report is we like to project what's going to happen in future months. So for example, the projection that we had for next month, June, was 24,250,000. Because this is 11 days into July, I can tell you we beat that number by over $1 million because of that extra million that came in that we wasn't expecting on the COVID. So it ended up being 25.4 or something, which was a good step into the new fiscal year that we need to continue to outperform our projections on cash. Is how I tend to look at us. Success or failure is, it's all about us having the flexibility and because the challenges are so great with the inflation of the master project, likely to be probably something more than the 19 million. We got to make sure we outperform our projections on cash.
Thank you. That's so helpful.
Any other questions? I'm trying to keep it big picture and not to repeat myself too much on things I've already talked about, but that's my presentation for the month of May.
Anybody else? Questions, comments?
Good job, Dave.
Thank you, Dave.
Thank you very much, Dave. Okay, that brings us to, there is no old business, so item G, new business, radiology billing concerns. And Gene, you had asked this be on the agenda. What's up?
Well, it's been a problem for a while, but Tim could address the changeover you made for the radiology reading. To me, it borders on fraud because they're illegally billing. They're supposed to be billing us, and they're saying they don't take Medicare. That's fraud. What's going on, Tim?
I've not heard that explanation of it. I reached out to them this morning and just to kind of get an update as to where we are with this thing. The decision to change companies was one that was kind of forced on us, primarily because our prior group had made a decision that they were no longer going to work in hospitals. As a matter of fact, they dumped all of the Dignity hospitals in Bakersfield as well. So, again, we had to go out shopping for another group. And there was one other group that we had worked with prior that we had looked at. That's actually one of the larger groups as well. But because of volume issues and so forth with us, they wanted to charge us premiums to make sure that they hit their profit margins and those kinds of things, which made that basically it's going to cost us a heck of a lot more money to do that. So we were going to have to augment what they got paid. Up until that point in time, they did their own billing and we got paid for, and they got paid whatever they got paid. And so the thought of us having now kick in money to help pay for the readings on those things was not something we wanted to look at. So we reached out to a number of other companies and came up with Regional Imaging. Again, they're an out-of-state provider, but they have ability to perform in-house. Again, it's all teleradiology, so it really doesn't matter where it happens from. But the issue is they hired a company here in California called Change Healthcare, and we do use them for other things to do their billing for them. And, again, so they mistakenly, I guess, was under the impression because Change had been here and is a pretty big player here in the state, that they could do the billing for them. Well, they can do the billing. The issue came down to the fact was that, again, some of the smaller local plans and that we have, they didn't have contracts with. And so they had to go out and negotiate contracts with those providers to do that. What he shared with me this morning was primarily that they believe now that they've got the bulk of them covered. And a lot of them, especially with the Medi-Cals and some of the others, the Medicares, they were holding back on the payments. And so they weren't going after and billing patients. There were some commercial plans, I believe, that they did. And they made corrections. We've been, I've talked with our admitting staff who gets those phone calls from the patients and so forth, and they would immediately reach out to Change Healthcare to alert them. And so those accounts would be pulled. So there would be no other further actions against the employee or against the patient, rather, excuse me. While they negotiated and worked out whatever the issue was that was preventing that billing from happening. He had indicated to me from his perspective that those issues were now down to a very small number as they're getting those cleaned up and they're getting those contracts in place. So I'm going to set up a regular meeting with them and with my billing staff here and with my radiology staff to address those issues and make sure that we have an ongoing monitoring system in place to assess any problems that are happening. So, and again, one of the things my staff shared with me is there were some concerns that had been raised. Some from the patients that maybe some of the Change Healthcare staff had been treating or talking to them a little rudely and stuff like that. And I mentioned that to the gentleman this morning, Joshua Blessing, and he said that's totally unacceptable, and he wants me to have our staff contact him immediately anytime those things happen, so that he can reach. He says they record all of their phone calls, so he said if they can go back and they can literally play those calls and see whether or not what happened. And so he said he's certainly willing to do that for us. So they got the message. I said, listen, this is, again, I recognize this was a quick turnover thing to get started. There was some obviously getting things up to speed, caused some issues. These billing things take a fairly long time to work out, these contracts and so forth, because of the credentialing of the doctors and all these kinds of things that have to happen before they'll finally approve you. So anyway, hopefully, like I said, we will keep these things to a minimum as best. And like I said, because I told him, I said, this is impacting us and people's perception of us. And I said, that's not tenable for us. This has got to get fixed. And he totally understood that. So like I said, I will make a point of keeping you apprised of how that goes from here out. See if I can't get some statistics from my staff in terms of the number of people that are reaching out to them with issues and concerns, and we can kind of begin monitoring their performance.
Okay, Tim,
Yeah.
whenever you have them, the radiation, the x-rays read by them,
Mhm.
they're supposed to bill Medicare
Yes,
or the HMOs or whatever.
correct.
Okay, twice in the past 6 months, they said, we do not accept Medicare. They billed me for $158 instead of getting the Medicare 70% discount.
Yeah,
They get 3 times as much money.
yeah,
I'm not the only one. Several of my insurance, I've said, Gene, what's going on?
yeah.
And Tim, that's fraud.
Give me some specifics, Gene. I'll be happy to look into that with them. I agree with you. Again, there's a problem there, and I don't understand that. So, but yeah, if you can share your statistics or your statements with me, that would be very helpful.
Okay, all right, thanks.
You're welcome.
I guess that's all. And if it's happening to me and several of my insurance come in here, it's happening to a lot of people, so.
Yeah, very possible. Okay,
All right, thank you, Tim.
you're welcome. Absolutely.
Okay, that brings us to item H on the agenda. These are directors' comments not appearing on the agenda. Gene, do you have any additional comments today?
No, we got a, well, yes, we have an awesome hospital, awesome employees, and they're gonna work with us on what we can do, and we need to do what we can, and show them, and be part, we're all together, so. All right, thank you.
Thanks, Gene. John, Director Blythe?
No, I don't have anything else today, Ross. Thank you, though.
All righty. Director Clark?
Dave, as always, thank you for the reports. They're very open. The way you prepare them even allows the public to understand what's going on. Thank you for that.
Director Elconin?
Yeah, I just want to say thanks to everybody that did the reports for Deb and, everybody, because they're just really important numbers that we get to hear.
Thanks, Catherine. Yeah, I don't have anything to add either. We'll go ahead and adjourn into closed session. We have 2 items to discuss in closed session, and then we'll come back from closed session when that's concluded and adjourn the meeting. So for now, we're going to convene into closed session.
Okay.
Okay, we are at item J on the agenda, the closed session report. Scott, if you could give that.
Yeah, so 2 items were discussed in closed session. The first was the performance evaluation of the CEO. The evaluation was presented, no action was taken. The second item was added to the agenda pursuant to a vote of the board, and that is Quinn versus Kern Valley Healthcare District, existing litigation. The item was discussed in closed session outside the presence of Director Elconin, and direction was given from the board to legal counsel. No other items were discussed in closed session.
Thank you, Scott. Okay, with that, folks, we are adjourned. We will meet again in about a month, except for our special meetings coming up with the building and planning and our committee meetings. So thank you all very much.
Thank you. Be safe.
Thank
Thanks,
you.
everyone. Take care.
Thanks, everybody.